Hello and welcome here at another episode of EAO's Just Ask Live, your monthly appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel, and tonight in this live video session we're going to try to answer as many questions as we can on the topic of peri-implantitis. And I'm very proud and honored to be joined by a leading expert on peri-implantitis who spent more than 10 years at the University of Montpellier as an assistant and associate professor, who is still based in Montpellier in the south of France, who is a periodontist with a specialism in implantology. Brenda Mertens, good evening.
Good evening. Hello, everyone.
Hi.
It's a real honor to be here.
Yes, so glad to have you with us. You're going to try to answer as many questions of our viewers as we can. But before we do that, we live in very special times, both personally and privately. How are you feeling tonight?
Well, a bit mixed feeling. Well, I'm at home tonight, and normally I should be at the clinic for the live.
Yeah. Yeah.
So I hope that everyone outside is healthy and well and stays at home. And of course, I'm thinking to all the person who are sick tonight, or all the person that, left from this earthly.
Yes. It's weird and delicate times, yet we are still going to provide as much knowledge as we can. It's live and interactive, although I want to invite all the viewers who watch this video on YouTube in recording, please follow along and let us still know in the comments your questions or reactions. We'll be going through and then later. Earlier, I posted in the live chat the question, let us know who you are and where you're watching from. And that is really kicking off. We have a truly international crowd with us tonight. I want to make some quick shout outs. Good afternoon from New Orleans in Louisiana, United States, says Mitchell Pierce. Diana Valente from Lisbon in Portugal is with us. And Diana, we have received your case and we will later go deeper into your specific case that you have submitted. So glad you're with us as well. We have Umit Yultsu from Ankara in Turkey. We have Alexandra Papadimitriou from Athens in Greece. We have Adam Dupuis from Paris in France. We have Zainab also from Paris. We have Ahmed Zekri, who is joining us from Cairo in Egypt. We see Daniela from London, Stavros Moisiadis from Athens also, Christopher Affelkist from Sweden, Serene from Lebanon. Truly, truly a very, very global crowd. So thank you all for being with us tonight, and use this functionality of the live chat to submit any of your questions that you have either beforehand or at the moment that you hear Brenda explain something, because it might take a few minutes until we get to it, but I'll be keeping my eye on the chat and relaying your questions on your behalf as well. So Brenda, tonight we talk about peri-implantitis. For those who are new to the topic or just in general, can you give us a short first introduction on the topic, the definition, and perhaps a little bit about the prevalence of peri-implantitis in implant dentistry?
Of course, it will be my pleasure. So first I want to share this slide with you. I'm sure a lot of you saw this kind of patients at your office. They all have periodontal and peri-implant disease problems. And they're all what we are going to talk tonight actually about peri-implantitis is like plaque-induced and biofilm-induced peri-implantitis, because there are different kinds of peri-implantitis, and I'm going to focus more on this ones. What I want to share also is a little thing that I check up on PubMed tonight, is actually when you put peri-implantitis in your PubMed researcher, and you find more than 2,500 actually articles talking about peri-implantitis. And then when you look more closely, then you see that the first article, which is really talking about what is peri-implantitis, actually was done by the group of Mr. Sanz, Professor Sanz from Madrid, in the 1990s. So actually it's 30 years ago. So we have kind of like a peri-implantitis 30 years anniversary. So I don't know if it's a good anniversary.
Very special night, a very special year. Yes, 30 years.
So if we go now, this is what you asked me actually, the definition and the prevalence. So first we need to talk about mucositis, which is the first step in this peri-implant diseases. And mucositis, I need just to put you on the side, is an inflammatory lesion, of course, of the soft tissues. And what is important, and there is an absence actually of loss of supportive bone. So there is only inflammation around the soft tissue. The prevalence is pretty high. is between 19 and 65%. It's high, but the range is pretty wide. This is because we have actually a lot of heterogeneity in the different studies that we have today. But thankfully, through this workshop, actually the EFE workshop in 2017, and with the new definition, I'm sure that we will have better results and better numbers in the years to come. So what is now peri-implantitis? Peri-implantitis, first we have the same inflammatory condition on the peri-implant mucosa like mucositis, but in addition, you have progressive loss of supporting bone. And when I mean progressive loss, it means that we have, the first year when you actually load your implants, you have like a remodeling of the bone, and this is not counted. You need to have at this moment a proper X-ray and then look in the different maintenance session if there is a progressive bone loss. And if there is one with this inflammation around the implant, then you can say that we have peri-implantitis. And the prevalence range is enormous. So it goes from 1%, which is pretty low, to 47%, which is like really, really high.
And so, Brenda, can you help me understand these range figures? When it's 1% to 7%, you mean some studies find a prevalence of only 1% and some find 47%? That exactly. Is what these figures mean.
This is because of the different definition that they use about peri-implantitis. Back then, actually, and also because of the different material methods they use, the different type of diagnostic principles they use, and so on. So I think today is also a good moment, to know how we do things, so that if you want to do like a clinical research, I don't know, then you have also some keys to do it properly.
Exactly. So you say it's very important that the diagnostics are the same, similar. Definition is getting standardized. What can you tell us about some of the diagnostic principles that we need to understand in order to properly diagnose this disease?
Yes. So there is diagnostic first, of course. We are clinician. We need first to look at the tissues. So when we look at the tissues, for example, if we see some erythema, swelling, or suppuration, then we know actually that there is kind of inflammation around the tissues. But sometimes actually it's more tricky than that. Sometimes you don't see it, and then it's mandatory to take a periodontal probe, and we will see it maybe later how to use it properly, and to do a gentling probing. I will come on that also later. What do we mean with gentling probing? The other thing is you can have also in mucositis a light increase of pocket depth because of the swelling of the tissues. So it's like a pseudo pocket. But again, no additional bone loss. So if you do the radio, the X-ray, you have no bone loss on the images. No additional bone loss. For peri-implantitis, the same. You have the clinical signs of inflammation. You have bleeding or probing and or suppuration, which can be like when you probe, or it could be more spontaneously. You have increase, of course, of pocket depth, but you can also have like a recession of the mucosal margin. And on the radiograph, you have bone loss in addition to initial bone remodeling. Now, if it's not your patient and you're not seeing your patient often, and it's like a new patient coming in your office, then you, of course, sometimes you don't have like the baseline X-rays. So for that, there is like an additional points to do the proper diagnostic. Is you can look on your radiographic image, and if you see a bone level which your bone loss for more than 3 millimeters apical to the most coronal portion of the interos part of the implant, then you know that there is a kind of a real bone loss going on. And in addition, it should be, of course, pocket depth superior to 6 millimeters when you probe gently, and at least bleeding on probing.
Okay. Just in the meantime, we see a very lively chat. Welcome to everybody joining. We have a truly global crowd. I want to pick out actually a great example I want to highlight. We saw the question from Giorgio Peviani, who says, will there be a recording of this live webinar? And the beauty is of having this international crowd together. We see Alberto Salgado already answering in the chat. Thank you very much, Alberto. And yes, indeed, to all viewers, as soon as this live video will be done, it will be available for resharing and re-watching here on YouTube as well. So I invite you all, if you know anybody who might find this video also very interesting, make sure you hit that share button and share this video to whomever you think this is of interest. Brenda, just double checking, when you talk about definition and about diagnostics, you keep making this clear distinction between mucositis and peri-implantitis. Why is it so important to determine the difference?
No, because mucositis is the first step to peri-implant disease. Sorry, periodontitis. I'm keeping saying periodontal disease, but actually it's the disease around the peri-implant mucosa. So it's really important actually to go and to diagnostic as soon as possible this kind of problems. And the first thing is to diagnostic actually mucositis, because a lot of studies actually are saying that if you treat mucositis, you are doing your best to try to prevent peri-implantitis. So this is why, and also mucositis, it's kind of reversible. It's not like gingivitis, not at all, but when you do the proper things and a patient is in the maintenance program and he do the professional plaque control system, but also at home he do everything what is needed to have a proper oral hygiene and so on, then you have a high chance of more than 60% at least to make it reversible. So this is a good point. So then you are actually stopping this kind of peri-implant diseases. But when you go then to peri-implantitis and you start to have bone loss, then we're talking about another topic, because this bone loss, actually, this bone is not going to regrow by himself again back. So then we go in much more complex treatments and so on. So yeah.
So that's why it's so important to understand and to diagnose the difference in what phase you are currently treating your patient.
For the next step.
Yes, exactly. You mentioned probing as a diagnostic opportunity, and Ricardo Trindade is asking, Brenda, is probing depth actually reliable from a diagnostic point of view?
It's real. I will go to the next step, because it's reliable if you follow some kind of rules. Okay, let's go on this.
Yes.
We all know, all the clinicians here tonight, we all know that there is a real difference anatomically between the tissues around the teeth and the tissues around the implants, right? So when you go and you probe, you cannot put the same forces around the tooth and around the implant, because if you do the same force, then you will traumatize actually the tissues around the implant. So you need to go more gently. In the literature, it says you need to go less than 0.25 Newton actually. But dependently which kind of probe you have, it's metallic, it is in plastic, which kind of brand it is, sometimes you need to go much more, you need to probe much more lighter. So sometimes it's like less than 17 grams actually. On the other hand, what makes it difficult, and this is what I can understand from our colleagues, is that sometimes the crowns or the prosthesis is in a such way that we have some kind of angle problems to really probe properly. So this is why the first things to do is beforehand, before we put actually implants and we're thinking about the prosthetic structure, we need to do prosthetic structure in such a way that first we don't have this kind of problems, but also that we can do proper oral hygiene professionally and at home. The gentle probing then is also kind of clinical feeling. You need to go in the sulcus and really gently just pushing your probe down. And you will see that you can actually rely on the probing that you have, because if the superstructure is not well done, then you will just probe less actually. That means that you will have, for example, 5 or 6 millimeters and not 10, But then if you see on the radiograph that there is actually bone loss, there is already bone loss that occurs, that you know that you're in a peri-implantitis field. So you need to go ahead and start with the treatment.
Yeah, so the other thing, in the basis, you would also always try to rely on both the radiograph and the probing.
You need to always to do a radiograph. I mean, exactly. At each maintenance, I mean, this is a subject to discuss actually, but normally there are like different consensus, and most of them telling that when you do a maintenance session, you need always to look clinically and radiographically to see if something occurred, because when we start to have problems, unfortunately, and we start to have peri-implantitis, unfortunately, sometimes it go really fast. So we need to double check always. And the other thing is we need to pay attention about the definition of mucositis, because I told you that we need to have gentle probing, and bleeding on probing is one actually on the factor to tell if we have an inflammation or not. But it's not just a dot. I mean, you need to have a real profusion or a real drop after 30 seconds after you did the probing actually. So pay attention not to have too much of these false positive mucositis cases.
Exactly. Well, I think that ties into a question from Mario Escobar, why we still see people joining. Elaine from Brazil, Michael Payet from Graz. Michael, good to have you. Peter van der School from the Netherlands is with us as well. But Mario Escobar is asking, which is your protocol for probing? And quickly following up for the radiograph, can you tell us a little bit about the devices you use for that? So can you share a little bit more practical in the clinic how you do this?
Okay, so there is like scientific and there is like my opinion, my way of doing things.
Exactly.
Okay, so like I said, for probing and the protocols, like the scientific protocols, they say just take a probe and do it gently. Okay, we know that the metal probes are thinner, so you can go more deeper inside. On the other hand, the plastic one are more flexible. So sometimes for the posterior area, the plastic is easier. So I have both, okay? And I double check. Then concerning the radiograph...
You double check, so you go both with the metal one and a plastic one?
I go always mostly with the metal one, but sometimes for the distal area of a posterior teeth, I take the, if it's hard to go inside, I take the plastic one. But I know that the plastic one is thicker. So I know also that I'm not going to have the real, pocket depth, the deep pocket depth. Concerning the radiograph, in the consensus, they say take a long cone radiograph, a classical 2D radiograph. In some other studies, actually, they say if you see that there is a problem, you can go for a cone beam so that you can analyze more properly the whole 3D defect of the bony defect around the implants, which is not always really easy also to analyze because the implant is in metal, and with the cone beam radiation, you have sometimes artifacts going on. But it's first you do 2Ds, of course, and if you see that there is a problem, and before you go on to more specific treatments, you can go on the 3Ds.
All right. Well, thank you for sharing that practical advice. Just let's take one more question on the probing, and then we move on to the next question. Because Ricardo Trindade, who also says thank you for the answer on his previous question, he says, what about anatomical changes in different parts of the mouth? For example, the mucosal thickness that might be different in different places. How do you take that into account?
For the
probing, he asked a question about whether probing was a reliable diagnostic tool, right? And then,
if the tissue is thicker and thinner, if you do a gentle probing, you normally it doesn't bother you. When you do, I know what he means, but it doesn't bother you when you do the probing. At least, if the prosthesis allow you to do a proper probing. This is, I think, for me,
that's
mostly
the comment you made before.
Yes,
yeah. So that's a big, I guess, a takeaway for people in the lab and people who are designing prosthetics.
For the colleagues who are doing the prosthesis, they're doing an amazing job because it's really hard, to to do something really functional and aesthetically. So yes, it's not.
We understand,
and we periodontists have always really high expectation of how to clean stuff. So.
True. Okay. Thanks for making that disclaimer. I scroll back to a question that came in a little earlier from Meshari Aldamk. I hope I pronounced that correctly. He's asking, can we predict the problem before it's happening? So can you say anything about risk indicators or risk factors in relation to peri-implantitis?
Yeah, so I will go on with the presentation because this is exactly what I will show you now. So first we talk about risk factors, risk indicators. I just want to make clear that actually it's risk indicators, even if we say risk factors, because it's just a semantic thing. So risk factors is only if we have really the articles that go for prospective studies, which is not the case in this field. So it's risk indicators. So for mucositis and peri-implantitis, so for all peri-implant diseases, of course, biofilm and plaque is one of the biggest and main factors. And then you have a lot of different secondary factors. I mean, the peri-implant diseases are multifactorial diseases. So we need to take into account several things. First, what is really typical only to mucositis and non peri-implantitis is that head and neck radiation can have also an impact and can augment the risk of mucositis. It's like. On the other hand, for all both diseases, we have, of course, the history of periodontitis, diabetes, if it's poor control of diabetes and you have high glycemic hemoglobin. Smoking, of course, is one of the big risk indicators also. For peri-implantitis, some consensus, not all, also define cardiovascular diseases as a risk indicator. Some medications, like bisphosphonates or non-steroidal anti-inflammatory drugs, actually, and also alcohol intake was also mentioned. So also, I will go to the next slide, but I just want to add something here, is when you see these kind of factors in your patients at the anamnesis, which is really important to do proper anamnesis, you need first, of course, if there is a periodontal disease, to go on to first treat the period. Then if there is a problem with poor control diabetes, you need to check with the physician, with the endocrinologist to see that. Smoking, you need to to advise actually some smoking cessation programs and so on, actually, for the different points. On the other point, there are some risk indicators who are not real risk indicators. I mean, they're all not common in our consensus, but some of them are say if there is excess of cement, of course, you have more risk to have inflammation and problems around your implants. And some of saying also, which is true, if you have a lack of attached keratinized mucosa, maybe you will have more problems. For example, discomfort when you brush your teeth, or teeth or around your implants, and so on. So you need to look at these points too, and of course the crown and the procedures itself, what I already mentioned before. So
exactly. So what I find the most fascinating takeaway when we talk about peri-implantitis, and I guess for you this is common, but maybe for patients who come across this video, the fact that we talk about risk indicators is mainly also because we don't yet fully scientifically understand how this disease originates, right? We see risk indicators that increase our or decrease our chances. But we cannot pinpoint and model, let's say, this is how it works and this is why this happens, right?
Yeah, what we know actually is that, of course, if you have plaque and calculus and things like that, it will augment your inflammation. So this is not a good point. You need really to think about that. And all the risk factors that we just saw, if they are like modifiable risk factors, you need to take them into account. But what is true, what you're saying, Gerrit, is that we don't know exactly how peri-implantitis occur. And we don't know also exactly how the conversion is between mucositis and peri-implantitis. I'm sure we will have some really good answers in the next years, because there's a lot going on in this field.
Many people researching this at the moment. Yes.
So, but at least for patients, what is important is that beforehand, and this is also what our colleagues and myself, we need to do beforehand, is before we do implant treatment, is to do all the information. That means we need to advise the patient that when he starts with the implant therapy, that means that we modify all the different risk factors. We start with the implant therapy, and then we need to have a really frequent checkup. A good supportive pre-implant therapy with a good interval between the different appointments.
Exactly. And we need to be really firm on making sure our patients understand that, right? Or
yes, this is really important. If we see that their oral hygiene is not well done, that there's not a real compliance with the patient, then honestly, I will not go for implant therapy. I will say, okay, no, this is not the point. This is not a good solution.
Exactly. Let's take some questions. We get some questions in the area risk factor or not. So let's see what we know about science. The first one came in from Pascal Valentini. And Pascal, I hope you're okay that I skip your first question about the probing, because we kind of moved on the topic of probing. He asked, what do you know about any science or studies or personal experience about whether regenerated bone is a specific risk factor for peri-implantitis?
Okay, we have the difference between regenerative bone with autologous bone, with our own bone, or with bone substitutes. With our own bone, when we go, there is not the difference, actually. When we go with bone substitutes, then we know from different consensus that there is a little bit of more risk to have peri-implantitis. Voilà.
Okay, so not a clear yes or no, but we've seen some studies where that was a factor.
There is a little bit of risk, but it depends on which kind of protocol we go for the bone regeneration.
Okay, interesting. Another one. What about, where is it? There it is. Andrew Halbert is asking, is there anything known or any studies done into different implant manufacturers and the varied designs as a factor in the risk?
There's a lot going on. Design.
You mean a lot of research in progress at the moment?
Yes, and industry-wise, what they are starting to do is there's a lot of going on of moderate rough surface or smooth surface. So they are trying to do hybrid implants in this site. And then what they're trying to do also, but I don't have, there is no evidence for that and so on. I know they're doing some modified surfaces with antimicrobials and so on, but yeah.
But this is all still work in progress. So
it's all, we don't have like the research on that, so.
Exactly. So yes.
But there is a lot of doing,
and into this.
Yes. But yes, and I'm also really thankful that the industry is working hard on this topic so that we can move on and maybe have less problems in the future.
Exactly. Well, as I said, we're going into the category risk factor or not. Gerasimus Carlos, greetings from Amsterdam, he says. What does the current literature say about vitamin D and risk for peri-implantitis / implant failure? What do we know about that?
Okay, there is not a clear consensus about that, but what we know, this is also what we know for nowadays, actually, is that vitamin D is really helpful for the immune system. Mm-hmm. So for the host part. So we know also that this is in peri-implantitis, there is also disruption with the host response. And it seems that if you have vitamin D deficiency, that you are more occurred to have problems with peri-implantitis. But we don't have, there are some articles on that, but we don't have like systemic reviews, or we don't have consensus on that for now.
Exactly. So,
but again, I can just like nowadays tell you that with what we are doing.
And this is then going to the direction that peri-implantitis could be an autoimmune response type of disease, right?
There is
that is the premise there.
There is, yes.
Yeah. But we don't know. But
it's never bad to take vitamin D and to have proper vitamin D level. Let's say it this way.
Exactly, exactly. A question from Jacek Popinski. Did you consider the corrosion phenomenon as a risk factor for peri-implantitis?
It's with titanium and there are some articles talking about that, and maybe in some patient that can have a problem, but we don't have we don't have consensus for that. So
exactly, I think that will be the answer to most of these questions, right? Because you've just shared where we have consensus.
But it's interesting because, of course, these are the risk indicators on which the science is working on, because we need to have more answers and we need to have more tools like to handle periimplantitis. So of course we need to understand.
Yeah. So let this live chat also be an invitation to all the researchers out there to pick up these research questions and let us know at the next EAO conference, or submit your abstracts. I think the deadline is coming up soon. I see a quick question by someone called Arveen, whether I'm Jamie Lannister reading questions. No, I'm not. My name is Gerrit Heijkoop and I'm the host of the EAO channel, but thanks for asking. Before we move deeper into more questions, we're halfway down or a half hour down the road, I should say. We already saw in the beginning that Diana Valente is with us. And those of you who've been following the EAO channels, literally the EAO channel on YouTube, but also the EAO social media channels, on Instagram, on Facebook, see the invitation that you can also submit your cases to our leading expert that is being hosted in the Just Ask live sessions like we have tonight. And Diana from Lisbon in Portugal actually took the opportunity and sent in a very extensive report on one of her cases, and also submitted some questions to you. So I think this is a nice moment to take a little break from the live questions and actually go into the case.
We go to her case. Just one point, Gary, just before. I just want to share this with our colleagues. This will help us actually to do the risk assessment and for preventing peri-implant disease. So you can check this on the Heitzman Field Implant Disease Risk Assessment. And because we talk a lot about risk factors, this is something that is a good tool in the clinic to help us to try to prevent all diseases.
Okay. Because you use this graph to kind of plot
it's your really patients. New. I mean, we know this from the periodontal field. We have periodontal risk assessment, which is really from Tonetti and Lang, which is really more easier than this one. But this one is a proposition that came just in January on. So we started to use it, but now we are locked down, so we don't use it anymore. But we're going to use it hopefully in a few weeks again soon.
Okay, and it basically means you plot your patient, and when you hit the red zone, that is a...
Red zone is severe, the other one is moderate, and green. It's not like the patient all is in red. It's like for some different risk indicators, it will be sometimes in red, sometimes not.
Okay, so it helps you quickly visualize what type of patient am I dealing with. Yeah, beautiful. Exactly. Thanks for sharing. Yeah.
You're welcome. So now going to the patient case. So thank you very much for this. Up, I will put you down. Voila.
Yeah.
So thank you, Diana, for your case. So looking at the anamnesis, we have here, I would say young lady, a lady 50 years old. She came to the private practice of Diana to solve the problem of her 12, what you can see here. She also noticed that she has a heart attack in 2017 and she's treated by aspirin or Coveran. So Coveran is actually a medication with two different types of molecules inside.
Okay.
So with the periodontal examination, there's apparently no pockets on all the tooth except on the implants. There's probing pocket depth in vestibular about 9, 8, and 10 millimeters on the vestibular side with bleeding and probing and suppuration. And on the palatal side, also really deep pockets for 9, 8, and 9 millimeters and bleeding and probing. And there's no occlusal trauma. What I can see also from the X-ray and from the patient view, clinical view, is apparently it's a perio patient, but it seems that the periodontal problems was treated and solved because we don't have like pockets at the moment. What I don't know, maybe Diana can just write it down, is if the patient came to the maintenance program really regularly or not. So that would be a good point.
Diana is already adding it's an antihypertensor. So that is all she's
Ah,
writing.
the cover, and yes, it's not
Yeah.
anti-hepatitis, so yeah.
Yeah. Okay.
Concerning the diagnostic classification, when we take the classification for Fromm and Rosen and taking the clinical part and the radiographic part, we know that it's a moderate peri-implantitis. And concerning like the bone defect, it's a class 2. I will add that it's not completely a class 2. There is also a slight little intrabony defect, what we can see on 2 threads actually. Okay, so the question, another thing what I don't know, maybe she can write it down, is if the patient was a smoker or not. What we can see, at least from the picture, is that there is some kind of plaque still going on.
Okay, here's Diana. This is funny. This is really live with the global average. Diana is adding, it was the first time in my appointment. So the first time she saw the patient.
Okay, so I presume this patient was not really followed. And so it's the first time. So here we come.
It was not her patient, she said.
Yes, exactly. So then we come in the diagnostic principles that we need to look with the X-ray and the peri-operation, with the periodontal examination, if it's a peri-implantitis or not. Where here it's really clear that we have a peri-implantitis product.
And it was a non-smoker. Well, thank you, Diana.
Thank you,
really good.
She is really following. Thank you.
Yeah.
Perfect. And another thing is, so we are in the aesthetic area, of course. I don't know if it's a low, middle, or high lip line, whatever. We treat every patient as if it was a high lip line, okay? So her questions was really good questions, actually, is what is first the best way to treat horizontal defects in aesthetic zones? Like I said, for me, it's not only horizontal. I think we have a combined, which is actually in the most cases, we have combined defects. And then the second point that she makes in the question is if we can solve it with regeneration, which is the best materials. I kind of started to answer this point before. So here, clearly, it's the first time that she sees the patients. And we have here really a big inflammation around the tissues and everything. So the first thing to do when we start any treatment like this, we need to start with non-surgical treatment first. Because we know that we need to have less inflammation in the soft tissue if we want to go on also. And also, nearly 40% of disease resolution occur only with non-surgical therapy, which is not a lot, but actually 40% is 40%. So here, it is clear that with these deep pockets, the non-surgical therapy will not be sufficient. But to do proper surgery afterwards, we need to have good soft tissues and less inflammatory soft tissues. So the first step actually is to go for non-surgical therapy. Then we do some reevaluation 6 to 8 weeks, actually 2 months after. And then, only then, we started with the surgery. Okay? So when we start with the surgery, we are in the aesthetic area. So it is clear that the first thing we do, we open a flap, and then we need to decontaminate all the surfaces, and we need to degranulate and to find again something more clean around the implant. We have here horizontal defects. What can we do with horizontal defects in general? Well, in general, when we have horizontal defects in non-aesthetic area, we can go for resective therapy. But here in this aesthetic area, I will not go for this therapy. Actually, what I would do is do for regenerative therapy fully, and then wait and see, because we will for sure have some kind of soft tissue recession, and then go, of course, also for this soft tissue reconstruction a second time. Voila.
Okay.
I don't know if it's... And then, for the materials.
Yes.
So this is kind of tricky because scientifically, like I said, there is no material. We have the gold standard with the autogenous clear, but the problem with it is that it resorbs too fast. So we need like substitutes to handle all this area. Now, the substitutes, there is in the science, in the articles, no material which is better than the other one. So this is one point.
So you cannot simply just ask that what is the best material, right?
No, yeah. And every surgeon have his preferences, but in the science, there is not such a thing that say it's better or not. Then another point, in regeneration, we use, of course, bone substitutes, but we use also membranes. In the consensus, normally they say we don't need to put membranes on regenerative, reconstructive surgery for around peri-implant bone disease. Bone reconstruction. Mm-hmm. As a periodontist, actually, we don't like to have bone particles in the tissues. So what we do is we put always a membrane on it, but a membrane that can be exposed. There is not high complication afterwards if we have a little exposure.
Well, you're already answering some questions from Chloe Garen Aboud, who says, do you
Sorry.
always use, that's okay. Do you always use a membrane for regeneration? And then there's quite some questions from viewers on the case. Diana herself is asking, would you use LPRF or combined with a xenograft? And other viewers are also challenging you then to at least share your own preference, and I think we should make a very clear distinction that science.
But I can go of one of my cases afterwards, which is an aesthetic case like Diana just showed, and then show the step by step what I'm used to do. Concerning LPRF, I don't have experience with it actually. I didn't saw different points in consensus records. I didn't saw something against it also. So maybe we should wait, or maybe asking another expert in another time.
Exactly, that's a topic for another Just Ask Live. And just I saw some questions coming in when you were talking about the case. Pedro Peña Martinez is asking about the type of prosthesis, cemented or screw retained, and the type of abutment. Does that matter to you in this case?
It matters to me if there is it matters to me in this sense that if it's screw retained, I can unscrew it.
Exactly.
And I can, for me, it's easier if I can submerge again this implant.
Exactly.
I know that some leading experts in this field, but some are liking submerged surgery, submerged healing, some not. Because the other point is, if you go for submerged healing, what's going to be your provisional prosthesis on the top? Well, here in the case of Diana, it's actually quite easy. She can just do a bonded bridge and then submerge on the thing. And then you don't have any forces going on the tissues that are healing at that time. So here, it don't seem, I think it's a cemented one.
It was. Diana is answering that as well. It was a cemented case.
So it's not easy. When it's like that and you handle it as it is. But of course, it's easier if it's screwed. So.
Exactly. And Brenda, there's a lot of questions, or a few questions also coming in about the cleaning methodology. The Jacques Hassid is asking, did you make an implantoplasty? The next question.
Okay, it's not my case, Jacques.
No, I know, but still, then refer to your own expert. Dean Danielle is asking, have you ever used laser? And also Isabella Rochetta is greeting you. Hi, Brenda. And saying, hello. What do you think about electrolyte cleaning of the infected implant surface? So these are all cleaning methods.
So this is about all the decontamination methods.
Yeah. Tell us a little bit about that.
We can talk like this. Otherwise, I can go on my slides. But so sorry?
If you have a slide ready that illustrates it, just skip to
it. We can go. Decontamination methods is something that we know a lot about it. So there are like mechanical decontamination and there are like chemical decontamination. So for the chemical, I will start with this. It's easier. For the chemical contamination, there is no consensus. You can go also only with saline, which is also really, really easy. On the other hand, you can still use chlorhexidine 2% or peroxide hydrogen 3% to clean around, but you need after it again to rinse properly. Okay, so this is for the chemical part. For the mechanical parts, it is clear that to be really effective, there are like three things that three different type of decontamination that works. First, which is really easy, and normally you all have this in your course, in your clinics, is abrasion air pollution systems. So this is really interesting for non-surgical and surgical approach. Then you have the titanium brushes, and for the titanium brushes, it is of course only when you have the surgical approach and you go on the threads and clean it. For that, you have different kind of brushes, long, small, and so on. They're really efficient also, and but sometimes a bit hard to access. So if, again, you can unscrew the crown, it's really easy. And thirdly is like the erbium-like laser, which is also really efficient on the contamination method. So then for the electrolytic part, which Isabella was asking, this is the group of Markus Schlee in Frankfurt who are working on that, actually. And this is a really promising area, I think, because when we look at in vitro and newly in vivo studies that just came out, it's just phenomenal. I mean, it's incredible. With this system, apparently, we don't have any kind of biofilm bacteria anymore on the surface, which we know that we put like moderately rough surface. So it's not easy to clean it really. And with this system, it's apparently really easy. But for now, it's not on the market. So, but we're waiting for it.
A little bit, how does it work? How does it, like, in practice?
So we have a cathode and anode. So it's like a battery actually working. And then you have the saliva is actually the vector. And then you put on this system. And the bacteria just attracted. So, wow. And the last study that just came out beginning of this year, they were comparing their own protocols, because at the beginning they were doing some powder actually of the surface on the implants, and now they just saw that we don't even need this powder. So it's even more easy to use it. But for now, we don't have it on the market.
And Brenda, when you refer to they, who's doing this research again? If people
it's Markus Schlee and all this team in Frankfurt.
Okay, well,
it's really, really nice personal. I mean,
that doesn't matter, but it's great research.
It's really promising, I think, area.
Exactly.
So
I agree. Yeah, sounds very exciting.
There are different promising areas. This is for decontamination. Another promising area in diagnostic was saliva biomarkers, where I'm really looking forward also. So it was just served.
Yeah, okay. You mentioned you had another case of your own for in the aesthetic zone, where you could maybe go a little bit more depth into the clinical examples and practices from yourself.
Yeah,
you also know that patient very well. I think it's interesting to.
I think it's interesting because it's also.
Before you kickstart the case, Brenda,
I will go on this first. Yes.
Yeah. Just a quick question that comes in from Gumba Tova. What do you usually recommend patients with implants, floss or interdental brushes? Obviously, with floss, you can reach deeper, but is that better? What is your advice?
Interdental brushes.
Clear, I mean, no doubt.
And you need to adapt it properly, because even if you have only one implant, you can have on the medial side like small brushes, and on the distal side more bigger. I mean, you need to adapt it, and every appointment, and you need to check that the patient also is able actually to brush properly. And this is also a point I forgot to mention it before, but before you go in implant therapy, you need to check if the patient is able to do proper oral hygiene. And sometimes he can do it in the front, but in the posterior zone is sometimes more difficult.
But would you then say, and perhaps you say that with your background as a periodontist as well, but would you say we should deny patients who we don't trust with their oral hygiene, we should deny them an implant beforehand?
I mean, what we know is for every surgery you start, whatever kind of surgery, you need to, perioplastic or even implant, you need to make sure that the oral hygiene is properly done.
Yeah.
So this is one thing. And it's properly done also because you need to instruct them, to show them how to do it, and so on. And then we need to focus on the prosthesis architecture that comes on the implant, that it's done in a way that patient also, if they become older or if they have some kind of diseases, I mean, we never know. I mean, if they have some kind of problems with access, that they can still clean it properly, or yes. And that we also as clinicians have a good access to clean it.
Yeah. But it's an interesting perspective and it's a philosophical one, so we'll stop it here. But it kind of is about where does your responsibility start and end, right? Because in the end, you could say, well, the patient is responsible for their cleaning, so they should understand if they get this, they should.
We need to do proper information before we start everything, and we need to be clear that the patient understands everything. And yeah, so it's also our responsibility to do things properly.
Clear. Show us your case about peri-implantitis in the aesthetics.
Here. So first, I just want to share with you this, because this is something, it's just a resume, and then we go in the case, if you want.
Yeah.
Up. Wait, it comes
the strategy model.
Yeah, sorry, it came on this one. This is live, huh?
This is live as in with a V. We are live, yeah. But in the meantime, if you're just joining us, we are live with Brenda Mertens, who's in Montpellier in France, and we're trying to take as many questions as we can via the YouTube live chat. We have quite a bit to go, so submit your questions as you can, but Brenda is about to show us a case of peri-implantitis in the aesthetic zone.
So before I start, it's just, I did a resume with all the different consensus that we have, and actually the strategy to treat peri-implantitis patient is in 6 steps. Like I said, we do the diagnostic, and we start always with non-surgical therapy. We do revelation, and then most of the time we go on surgical therapy. And then we have the options actually on only doing an access flap, or we do regenerative reconstructive surgery, or resective, or sometimes, unfortunately, we need to do explantation, and so on. Mm-hmm. So this was the resume, was what we saw before, that we have a lot actually of class 2, which is like this one. I don't know if we see my...
Yeah, we see your mouse as well.
And then 80% have a class 2 defect, and 55% has also combined and 1E defect, which is really intraosseous defect, like a crater, which is really easy then to do regenerative reconstructive therapy. So this is another one. So in the aesthetic area, I want to present you Mr. D, which is 35 years old. He was sent to me by a colleague. And as we can see, there is a huge problem between the 11 and the 12. And also what we can already see, and there is a discrepancy between the lengths of the 11 and the 21. And I can assure you that, knowing my colleagues, this was but perfectly aligned 8 years before when they did the treatment. So that means that we have in between had some kind of craniofacial growth also here. Mm-hmm. Okay, this is the X-ray from 2010. Here's the clinical side. You can see that there is a real inflammation, swelling, and also redness of the tissues. We have a recession also between 11 and 12. We can also see that they are pretty close to each other. And we can see also a lot of plaque on the implant. When we do the gentle probing, we have nearly 8 millimeters of probing pocket depth. And when we look at all the X-ray, we can see that we have also at least 3-5 threads which are occurred to be where there is some bone loss. Okay, so we started actually with the non-surgical therapy, and then we went to the surgical therapy. So this is actually, when I opened the flap, what I saw. So you can see that there is a huge defect on the vestibular side, huge defect also in between, and we have here combined defect, horizontally and vertically defect on the implant as also on the tooth. So we need to actually treat both of them. Mm-hmm. We see also there is a lot of granulation tissue. So what we do is first, of course, we need to eliminate the granulation tissue. For that, we need the curettes. And then, like I said, to decontaminate the surface, it's really easy to just take the air abrasion air pollution system to put all these particles on the implant surface, and then we need to rinse properly. Just a little point on that, because when you use air pollution system, you have different kind of powder that you can use. Okay, so for non-surgical therapy, you go always with glycine particles, but we know that on the implant surface itself, sodium bicarbonate is more effective, but on the other side is really aggressive for the tissue. So you can do it, but only when you are in a surgical approach, of course, because then you can be more precise.
In the meantime, Pascal Valentini is noticing. Oh, okay. You just answered his question. He noticed the gap between the implant and the abutment and how you manage that, but he just retracted his message.
At the implant and the gap, this is not a. Then this is how it looks like just after you air polish everything. You need to rinse properly, and then what we do is. To make sure we go still with chemical action. That means I take a little pellets and then soak it in chlorhexidine or peroxide and really mechanically going on the surface so that the products go inside the different valleys of the surface to decontaminate once more chemically. And then we rinsed it all. Once we did everything, then we went for a regenerative procedure with xenovine material.
Okay, so and this was a xenograph you used in this case?
Yes, I used xenograph because it's a slow resorbable. And then the membrane, put it inside, and then closure. So this is the first step of the surgery. We know that this kind of surgery is functioning. We know that we can have good reosseointegration with this kind of regenerative therapy, also with rough implant surfaces. But we know also that in this kind of cases, we have an aesthetic area and we have already problems with soft tissue recession also. So after 6 months of wound healing, we go also for soft tissue reconstruction. So, and the soft tissue reconstruction, we know the different techniques from the perioplastic surgery advice. We know also that, and this is a more recent study that says that it is better to use connective tissue graft in this kind of cases than a substitute material for the soft tissue management. So secondary, what I use is, these are just the end situations. I use a really fatty graft, connective tissue graft. Why? Because I wanted here a lot of cells, and I wanted here I know that a part of it will be exposed. So I know that the vascularization will be more efficient when I do it in this way with a more fatty connective tissue graft than what we use in perioplastic surgery, where we just need something really dense. Sorry. Okay. And this is like the situation just after, 4 months after the surgery. So we can see that we have just a peripocket depth of 4 millimeters without bleeding. And we have a nice contour now around these two tooth. And this is what the situation before. What we can discuss here is, of course, some clinician would, and I had this maybe idea also, is to go and maybe to explant actually the implant and to reconstruct everything and to start new. But the patient didn't want this kind of option. So it was much more challenging to go step by step in this way. But at the end, I think we had something not too bad. What needs to be done now is all the prosthetic part need to be done now in this field.
Exactly. So basically, you say you took a more complex approach in this case because also the patient didn't want to go for the explantation.
Yes, the patient said, "Well, I don't have a high lip line, as we can see in the beginning. So he said, well, it doesn't matter if we see a little gap, and doesn't matter if he said we can, if we need to expand, we can go in a second stage. So first try it. And actually I thought it's quite smart, because in periodontology, this is actually what we do first. We want to keep teeth, and we want to do everything which is possible before we before we extract. So I was then thinking, well, maybe you're right. We need to fight for it first. And
take a conservative approach.
Yes.
Lawrence Blackie Swart is asking, did you ever consider changing the prosthesis from a cement retain to a screw retain prior to the treatment?
Yes, this is what I mean. I don't do myself the prosthesis part. This is my colleague, which is a bit far away when doing it. Yes, this is something that is going to be done, actually, because also of the discrepancy of the length of the tooth and so on. Yes.
Okay. And Vadim Sandulyak is asking, do you have a frontal view of the end result as well? And I think
front review
of frontal view after CTG is asking.
But this is like the end. This is the end case.
That is the end case. Okay, yes. Clear.
So you have it here. So again, here. So you can see here is like the graph underneath. And then here you can see like this is why I put you the baseline too, because the baseline is really flat. Here it's like more bumpy.
Clear. Yeah. Thanks for clarifying. Well, we have about 10 to maximum 15 minutes left to take as many questions as we can. We see some questions coming in. Let me see.
And I want just to add something also here. If you have, what would have been also more easier, is if we had the possibility to unscrew into what I said before, to take like the crown down and then to submerge again the situation. But like I'm in Montpellier, this patient is living in east of France, and then so it's a bit complicated, but I think we manage.
And then the key question, of course, before we close the case, how long ago is this, and did the peri-implantitis stay away?
It depends on all these factors. I mean, stay away.
For now, I mean.
So the disease resolution is achieved. I mean, this is clear. We don't have any disease for now. If the patient continue with a good oral hygiene, and we can stay like this for a few years, but I don't know with the other factors. I mean, at least this patient is a non-smoker, really healthy, really sporty, so still
should be
yes, should be good.
Okay, I'm going to try to group a few questions that I see coming in. Let me close your screen with this case, because we see both Pascal Valentini, but also now Mario Escobar talking about the relation of the implant material to peri-implantitis. So Pascal is asking, what about ceramic implants? Do they perform better regarding biofilm adhesion than titanium implants? Maria Escobar is also just submitting, what do you think about a hybrid implant, titanium with a coronal zirconia waist, to be more fibroblast attractive? What can we say about that? Let's start with any scientific knowledge that we know about this.
Okay, what we know is if we have some problems, I mean, if we have peri-implantitis, that's the healing is much easier around the smooth surface than around the rough surface, of course. So this is why a lot of industry actually goes on these hybrid implants. Do we have more prevalence around zirconia than around titanium implants? I mean, zirconia implants are now there for 15 years approximately. There are some failures going on, but there are more fractures than peri-implantitis.
So you mean when you look at the incidence of failure, the failure is often more fractured,
more technical than more biological. But for now, I don't know any consensus that said, let's go now for zirconia implants because it's better in general, you know?
Exactly. So yes, there's something with
so,
services,
so
but we
I think for the
say
future there is something to I think the different zirconia implants are also improving. So I'm sure that with this, maybe there's something to do it. But we for now, we cannot say that it's better or not. But it seems that there is less biological problems around zirconia for now.
So too early to call definitive.
But there is no consensus for now.
Exactly. There's no hints, but something to
but
keep
there is some
track.
Articles and some research.
Clear, thanks. Andrew Halbert, another topic that we kind of circumvented, and maybe you should explain why, but is about the effect of the surgeon and the surgical procedure. And Andrew Halbert is asking, you did not mention it, but how often might these problems be present when the surgeon has limited knowledge and or expertise relative to planning and surgical technique? And I know you and I talked about it briefly in our pre-call, but please explain why that is a
really good point. I think it's one of the 3 pillars, actually, for peri-implantitis. I really just mentioned a bit at the beginning is that we need proper planning, and we need people. I mean, we need surgeons that now know where to put implants, how the tissues need to be beforehand, how we need to manage it, how the procedures construction needs to be. And of course, I mean, we have our part of responsibility if we don't do it properly. And of course we are adding, and of course we are one of the risk factors for that too. I mean, and I think there is a really learning curve also in implantology. And for example, aesthetic area are not that easy. It's like, I think we need to go step by step, learning properly, and then do the things according to science. So, and thanks for this question, because of course we surgeons have our part of responsibility.
Yeah, but we said before we're not going to go all the way deep into the different surgical techniques on this one, right? No. Because when we come near the end of our Just Ask here in April, let's see if we can summarize. What would you hope are the key takeaways, the key take-home message that the colleagues watching are taking away from this?
For me, the key message is prevention. Mm-hmm. Prevention starts beforehand. First, as a periodontist, we say try to prevent and to keep the teeth. There's nothing better than a tooth. Then when we are in implantology, of course, we need to have proper oral hygiene instruction. We need to manage that the patient is a good maintenance program, that he comes at least twice a year to the appointments. That is the risk, all the modifiable risk indicators need to be screened before and need to be really treated before. And then, of course, the patient needs to understand also his prevention, which is his everyday home care, oral hygiene. And we as clinicians need always to pay attention if there is some kind of inflammation around an implant, not to overlook it, but really to go deep in it and to pay attention that it's not a peri-implantitis and it's not going too far. Because when we're treating peri-implantitis, it's of course a bit easier to treat the beginning of it than if it's already I mean, if we have too much bone loss, and then it's really hard to manage it.
Exactly. So that's a very
for
clear
me, it's
message.
Prevention. The
prevention
key.
With all capital letters, right?
It's
really be aware of it. Include our patients in these protocols. Make sure we see them often, that they understand the importance even before they receive the implants.
And always have good protocols, have really good, follow good the guidelines, and have good checklists in every step, what you do from the pre-surgical part, the surgical part, the post-surgical part. Yes.
Yes.
And
Well,
to
with
involve the
that,
patient in it.
yes, the patient is key in this one.
Yes.
Well, with that, Brenda, I want to near the end. Already, we see a lot of people congratulate you on YouTube. Bravo! This is an invitation. Let Brenda know what you think about this. Just ask, because she's definitely going to read that all back. And remember, as soon as we stop this live session, it will be available as a recording here on the EO channel on YouTube. So if you haven't done already, make sure you subscribe to the EO channel. Hit the subscribe button on YouTube right now, and make sure you also hit that little bell so you'll get a notification as soon as the next EO Just Ask Live or another important video about implantology is published. You get a notification. You'll be the first to know when a new video comes out. If you want to, please look up our future episodes of EO Just Ask Live and make sure you submit your case. If you have a case about a certain topic, you can submit it. Make sure you double check all the prerequisites. Make sure your patient has consent, or at least all your data is anonymized, so you are aware that you share this data in a public domain as well. And if you can't get enough of these sessions, make sure you check out all the other Just Ask Lives. We have the sinus lift with Alberto Sogado. We have ceramic implants with Michael Payet. We have soft tissue management with David Nissan. Guided bone regeneration with Isabella Rochetta. And fixed implant prosthodontics with Arina Saylor. And now, Brenda, we're adding you to this amazing lineup and library. Peri-implantitis with Brenda Mertens. Thank you very much. And we
thank you, and thank you all for all your questions. Thank you.
Yes, we hope to see you all back at the next EO Just Ask Live.